Understanding your risk is, I think, one of the most important concepts that you need to understand when you're facing a cancer diagnosis because it basically impacts every aspect of what comes next. The initial treatment for your cancer, be that surgery or chemotherapy, or sometimes hormonal or endocrine therapy, any post surgical or what we call adjuvant treatment that may be indicated for your specific cancer, as well as any surveillance plan that your oncologist may recommend once your cancer has been initially treated, meaning any subsequent follow ups or scans that may be needed. And I would say the most important type of risk to understand is the risk for a recurrence, right? The risk that your cancer could come back once it's been initially treated, or the risk that it could possibly spread to other parts of the body. We have a number of what we call clinical parameters, as well as some additional advanced technologies available today that oncologists can now use to determine your risk. And I'll use the example of a breast cancer diagnosis for an example here, since my wife of 20 years was dealing with this 2 years ago. But the general concept of recurrence risk really applies to all cancers, even the blood cancers, albeit those are just a little bit different than the solid tumors. So if you're diagnosed with, for example, a breast tumor, as my wife was, generally speaking, an initial what we call curative treatment is a surgical removal of the primary tumor, right? Get the cancer out of your body first. So what usually happens after that is a biopsy, meaning they will examine the cells of that tumor in a number of different ways. They will assess whether it has spread beyond the primary site of the cancer, and based on the findings, determine what we call your risk for recurrence, your overall prognosis, meaning what the expected course of your disease is likely to be. And we have a number of different parameters we can use to determine that. First is the size of the tumor, which is usually measured in centimeters. And as you might expect, the larger your tumor is, the more mass, the greater the number of abnormal cells that are present, the greater the risk for recurrence, and the poorer the prognosis, right? Because the tumor has had a longer time to grow. A second factor that determines your risk is whether your cancer has spread to the nearby lymph nodes. So there's small organs throughout the body that are close by to where the primary tumor was. And if the tumor has spread to your lymph nodes, how many of those lymph nodes are involved? A third factor that determines your risk is whether the cancer has spread beyond the primary site of the tumor. Has it spread to other parts of the bodies, like the liver or the lungs or the bone? Once again, as you might expect, the greater the degree of spread to other parts of the body, the more sites that may be involved, the poorer the prognosis, and the higher your risk for a recurrence of your cancer is. Having said all that, you can understand that your overall prognosis, your overall risk is a lot lower if you have a tumor that is very small, that has not spread to the lymph nodes, and that has not spread or metastasized to other parts of the body. Your risk will be much lower versus, say, a very large tumor with multiple lymph nodes involved, and which has spread to another part of your body, like the liver or the lungs. You can also understand from that your oncologist will prescribe a very different course of therapy or treatment if your recurrence risk is very low, and on the flip side, that your prescribed treatment is likely to be much more aggressive or intense if your risk is very high. So without getting into too much detail, I just mentioned, in addition to things like size, lymph nodes, and metastasis, we have a lot of other tools right now that can help your oncologist to determine your overall risk. And some of these are what we call biomarkers, things that we can measure in your blood or that can determine your risk. In the case of prostate cancer, for example, we talk about things like PSA or prostate-specific antigen. That's just a different biomarker for how fast that cancer is growing, whether it has recurred. It's something we can measure in your blood or in a biopsy of the tumor itself that we can also use to determine your risk. And I also want to mention that we now have a number of what we call genomic classifier tests, which basically is a fancy word for it. It just looks at the genetic information in the tumor, the DNA of the tumor, to identify some specific molecular changes that might also help to determine your recurrence risk. I'll use the example of one of these tests that's very often used in breast cancer and other cancers to determine the need for adjuvant therapy or therapy after surgery that can help to reduce the risk of your cancer coming back. In the case of breast cancer, this is usually chemotherapy or chemotherapy type of adjuvant therapy with or without what we call endocrine therapy. The test is called Oncotype, and based on the results of the testing, you are assigned a recurrence score. And that helps the oncologist determine whether using endocrine therapy alone or endocrine therapy plus chemotherapy, called chemoendocrine therapy, would be the best treatment option for you. That's going to reduce your risk the most. Within this particular test, the higher the recurrence number, the higher the risk of a recurrence, and the greater the benefit of adding endocrine therapy either alone or with chemotherapy towards reducing your risk. So let's back up a minute and say, how do they really assign your risk? Well, this is based on what we call historical data, meaning what were the outcomes in a very large population of patients with the same type of tumor as you, the same clinical characteristics as you. How did those patients do with or without treatment relative to other patients when we looked at them over very many years? Now, one thing that I think is critically important to understand about your risk is that it's really not a hard and fast number. It's basically a statistical calculation. It's an estimate. Really, it's just a guess. Now, don't get me wrong here. It's a very good guess because we're basing that number on information that we have for very large numbers of patients looked at over a very long time. In breast cancer, for example, we're talking about patients that have been studied for over 25 years or more. But here's the problem with that. Over those 25 years, what has happened? Technology is advancing. The treatment of breast cancer or any cancer, it's evolving. We have new drugs, new types of therapy. So it's important to understand that over time, the way we treat cancer is always changing dramatically. A second thing that we also have to recognize when we talk about risk is that, yes, these were very large studies with very large numbers of patients. But unfortunately, for example, in the case of breast cancer, these were predominantly Caucasian, largely European populations of patients that were studied. So we now recognize that because of that underrepresentation of Black individuals, for example, the data on their risk is just not as strong. It's just not as reliable. So again, what I think it's really important to realize is that risk is really just our best possible estimate for your specific cancer based upon all of that historical data. So let's get back to the example of my wife's result, right? Her tumor was small. It had not spread to any lymph nodes and had not spread to any other parts of her body. And her Oncotype recurrence score was 12, which was relatively low. They can go up quite high. But based on that result, her risk of recurrence of her breast cancer was estimated to be about 3% at 9 years after her diagnosis, meaning that about 3 out of 100 patients with that score would recur if she were to take endocrine therapy alone. Also based on those results, it was estimated that the addition of chemotherapy to that endocrine therapy would reduce her risk by less than 1%. Now, as we all know, chemotherapy can have some very negative and potentially dangerous side effects. So from that perspective, the risk of the treatment was not worth the benefit of the treatment. Now, if that number was different, if her risk of recurrence was, say, 20% over a 9-year period, and the chemotherapy could reduce that risk to about 10%, some patients might consider that course of treatment was worth the potential risks. But in my wife's case, it was not. Also, based on her recurrence score, if she chose to take endocrine therapy as adjuvant treatment, meaning after surgery, to prevent a recurrence, her risk could be as low as 3% over that same 9-year period. My wife decided, however, that she did not want to take endocrine therapy because of the potential side effects and the need for taking a pill every day for what is generally a 5-year course of adjuvant treatment. Because she chose not to take the endocrine therapy, her risk essentially doubles from that 3% to about 6%. Another way to look at that is to say she has a 94% chance of being recurrence-free for 9 years if she chose not to take endocrine therapy, as opposed to a 97% chance of being recurrence-free if she did take the endocrine therapy. Now, one of the more, controversial statements that I made to my wife during her initial cancer journey, which at first she was somewhat taken aback at, is that, you know what, all drugs, all therapies have risks. Nobody's got a gun to your head. Nobody says that you have to do anything. It's your body, it's your cancer, and you have to do what's best for you. What I really want to leave you with from this discussion about risk is that at the end of the day, you have to decide what you are comfortable with. My wife happened to be satisfied with that 6% risk, but you may not be. Everyone is different. You may want to do everything you can to reduce your risk as close to zero as you can get. You may want to go for that 3% and be willing to accept the potential risks of your prescribed treatment and the side effects of that treatment to get to that 3%. Again, at the end of the day, it's really up to you. If you're facing a cancer diagnosis, like I've said before, the best thing that you can do is learn what you can about your specific cancer, your specific risk, your prescribed course of treatment, and the risks and potential benefits of that treatment, whatever that might be. And of course, talk to your oncologist if you have questions, because they will have all the specific information about your specific cancer diagnosis, as well as its implications. Thanks for watching. Hey, if you like this video, I invite you to subscribe to our channel, and please feel free to share it with your colleagues and your patients. I hope you find it useful to navigate yourself or somebody you know through a cancer diagnosis and the many difficult decisions that can come with that. And please feel free to email me at peter@totalhealthconferencing.com with your questions or comments, or if you have a topic you'd like to see us discuss. Thanks for watching, and we'll see you next time on Cancer Comments.